light போடணும். இந்த லைட் ஆஃப் பண்ணணும்டா. அது சரி, இதா இந்த ரெகுலரா போடுறவங்க இது பண்ணாதான் சரியா இருக்கும்.
Respected senior doctors of the profession, IMA Junior Doctors Network team, Medical Students Network team, postgraduate students and colleagues, a very warm and happy evening to all. On behalf of our chairman, directors and the entire SAH team, we welcome you all for our monthly virtual CPC meeting. We shall now start our virtual CPC meeting with the interesting quiz questions. First, we have a clinical picture of a 35-year-old male who presented to the emergency room with alleged history of head injury following a road traffic accident 3 days ago. On examination, he had hyperacusis of the left ear, sensation of the left mastoid was absent, and taste sensation in the anterior 1/3 of the tongue was also absent. With this history, what do you think could be your clinical diagnosis? The patient was subjected to various investigations and a CT brain and a skull was also taken. What does a CT film show you? And according to the examination findings, what will be the location of the 7th cranial nerve injury? What are the causes of unilateral element type of 7th nerve palsy you can think of? And how will you manage Bell's palsy? Next, we have an ECG of a 45-year-old male who came with features of obstipation. His preoperative evaluation showed a BP of 120/80. His pulse rate was normal, saturation was fine. On auscultation, an S1 was heard at the right 4th intercostal space and at the right 5th intercostal space. Per abdomen examination, he showed a distended abdomen with increased bowel sounds too. And this is his first ECG. And what do you think are the findings in his first ECG? With this, what will be your clinical diagnosis you can think of? And what are its types? How will you further evaluate this patient? Another second right side ECG was also taken for the patient, which is shown here. And what do you think are the findings in it? With these findings, what can you think of the syndrome associated with this condition? And with this, what will be your final diagnosis? Next, we have an interesting clinical picture of a 65-year-old man who was admitted in view of angina, and he had the clinical findings as shown in this image here. On examination, his BP was 110/70, pulse rate was 112 per minute, saturation was a little low. And with this, what can you think of the differential diagnosis you can offer in this patient? What is the clinical diagnostic sign that differentiates lipoma from other diagnoses? And what are the other syndromes you can think of which can be associated with this condition? And what are the complications expected? Next case, we had a 62-year-old female who came with a mass in the left side of her neck and pain in the left upper limb also. Patient gave a past history of having undergone a thyroidectomy 13 years ago. On examination, her BP was 140/90, pulse rate was 86 per minute, saturation was 98% at room air. Her random blood sugar is 134 milligram per deciliter. A cervical node biopsy was performed for her, and the biopsy came as a poorly differentiated malignancy of unknown primary. So in search of the primary, a PET CT was done for this patient. So what does the PET CT show us here? What are the findings you can think of here? What are the examples of tumors with reduced FDG uptake you can think of? And what is the preferred line of management in this patient? Next, we had a 68-year-old female who came to our OPD with complaints of painful fluid-filled lesions involving both her lower limbs, her groin, hip, oral cavity, elbow, which was not relieved by medication, following which a skin biopsy was also done for her. With this history, what is the clinical diagnosis you can think of? The biopsy slide is also shown here. And what do you think are the findings in it? What could be the cause of this condition you can think of? What are the expected complications? What are the drugs implicated to cause this condition? And with this, what will be your preferred line of management for this condition? Next, we had a 59-year-old man who was admitted with a known case of decompensated liver disease with hepatic encephalopathy features and portal hypertension along with hematemesis. And for this patient, an EEG was taken for him. What does his EEG show here? What is the interpretation from this EEG you can get? What are the causes you can think of? What are the different types of normal EEG waveforms you know? Next, we had a 55-year-old male who came to our emergency with complaints of breathlessness, weight loss, and fever. An X-ray was taken for him, which is shown here. What do you think will be the findings in this X-ray? What do you think would be the cause for it? What is the pathophysiology of its formation in the lungs? And what are the differential diagnosis and the complications of this condition you can think of? Next, we had a 25-year-old female who presented with complaints of tiredness, weight loss for the last 3 months, and dry cough for the last 2 weeks. On examination, her vitals were stable. A systemic examination was normal. With this history, what will be your clinical diagnosis? How will you proceed to evaluate her? The patient was subjected to an X-ray chest and a CT, which is shown here. And what do you think are the findings in the X-ray of this patient and the CT film also? And with these findings, how will you manage this patient further? Next, we had another interesting case, a 58-year-old male who presented to our emergency room with complaints of yellowish discoloration of the eyes and right hypochondrial pain of 2 months duration. Patients are chronic alcoholic for the last 30 years. On examination, he was conscious, oriented, icterus was present. Per abdomen, there was tenderness in the right hypochondrium, and he had a hepatomegaly, which was very hard in consistency too. His BP was 130/90. With these clinical findings, what will be your clinical diagnosis? How will you proceed to evaluate him? Apart from the routine investigations, we had done an MRI abdomen for him, and the film is shown here. What do you think are the findings in it? With the above finding, a biopsy was done, and here the histopathology specimen is shown here. The slide is, you can see. What do you think are the findings in it? And what are the risk factors for this condition you can think of? Next, we have a 31-year-old male, a chronic alcoholic and smoker, who came with on and off epigastric pain, radiating to the back since 1 month, vomiting for 2 days. He was on examination, he was afebrile. His pulse was 96 per minute. Per abdomen tenderness was there in the epigastric region. With this history, what can be your clinical diagnosis? How do we proceed to evaluate him further? We had subjected the patient to an ultrasound abdomen and also a CT abdomen. The film is shown here. And what could you think are the findings here? And how, with this, how will you manage your patient? We had another interesting ECG here. A 55-year-old male, a chronic alcoholic and smoker, came with chest pain and was diagnosed to have infraval MI. Patient was thrombolized. He became unresponsive after 5 hours of thrombolysis. He's a known diabetic, hypertensive, and also a coronary artery disease patient. His BP and pulse were query. His heart sounds, we are not very feeble, we could not hear it. The ECG shown, the first ECG, as you can see here. What do you think are the findings in his ECG? How will you proceed further? Immediately, another ECG was also taken for him. What do you think are the findings in it? What do you think are the causes of these findings? With this, what can be your final diagnosis and how will be your further line of management? Thank you. So as our participants and delegates are pondering over the answers of the quiz questions, we shall now start our meeting with a prayer, as everything starts with the Almighty. Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I may rely on thee. SAH prayer. Almighty Lord, the source of pink health, we submit our heartfelt gratitude for healing the dreadful and the chronic patients through our hands. Bless our Sundaram Arulrhaj hospitals with all the doctors and staffs. Let them shine up in their efforts to heal the sick and develop the science of medicine. We thank you, O Lord, for picking us for the health services to create a healthy longevity for healthy citizen and healthy, vibrant India. Thank you. So we shall start our CME now. And the first talk for today evening will be on cardiorenal syndrome, which will be presented by our highly energetic consultant nephrologist, Dr. Subhashri ma'am, who has done her MBBS from Government Chengalpat Medical College and DM Nephrology from Government Stanley Medical College. She has won many awards like the Tamil Nadu Dr. MGR University Medal for Nephrology 2021 and the Best Doctors Award, Thoothukudi District 2022. Her interests are on pregnancy and kidney health, renal transplantation, and acute kidney injury. She has done various publications in index journals and chapters too. She is a reviewer of the Indian Journal of Transplantation. We're very happy to have you today with us, madam. Over to you, ma'am.
Very good evening to senior faculties and internal medicine postgraduates. Am I audible to you, ma'am?
Yes, ma'am, you are audible. You can share your slides. Yeah.
So are my slides visible to you now?
Yes, ma'am. Now it's visible. You can make it a full screen now.
Fine. So thank you, madam, for the very kind introduction. And at the outset, I would like to thank Aarti ma'am and Arulrhaj sir for including me in this academic feast. So I'll be talking to you about cardiorenal syndrome for the next 10-15 minutes or so. So it was as early as in 1913 that Lewis hypothesized or postulated that cardiac dysfunction contributes to dyspnea in a patient who has got uremia. So heart and kidneys are inextricably linked to maintain homeostasis in a particular individual, and this communication will happen at multiple levels. So the dysfunction of one organ will invariably lead to dysfunction of the other, though the intensity and the timing may vary. So to define cardiorenal syndrome, it is defined as disorders of heart and kidneys whereby acute or chronic dysfunction in one organ may induce acute or chronic dysfunction of the other. Now, we are all familiar with the types of cardiorenal syndrome, but just to recap, type 1 is whenever there is an acute heart failure leading on to AKI, it is type 1 acute cardiorenal syndrome. Type 2 is a chronic heart failure leading to a progressive and permanent chronic kidney disease. Type 3 is when an acute kidney injury is causing an acute heart failure. And type 4 is a chronic kidney disease that leads to chronic heart failure and CKD progression. And finally, we have the type 5, where there is a systemic insult either in the form of sepsis or it could be amyloidosis, diabetes, etc., which simultaneously results in organ injury of both the kidneys and the heart. Now, there is also a proposed classification based on the putative pathophysiology implied. It could be hemodynamic, it could be uremic, vascular, neurohumoral, etc. But this classification has still not been put to practice, probably because of the complexity involved. Now, having said that, there are 5 types of CRS. The real case scenario is actually very difficult to diagnose that your particular patient falls into this particular type of CRS. Why? Because a patient with chronic kidney disease can have an acute worsening of renal failure, which predisposes the patient to have either an acute coronary syndrome or an acute heart failure. And it could also be the other way around. A patient with a chronic heart failure with an acute decompensation having an acute kidney injury. So to pinpoint that this particular patient has got this type of CRS is actually difficult in real case basis. Now, why are the kidneys involved? Because kidneys have low resistance circuit, which receives a disproportionately large amount of cardiac output. So whenever there is an increased central venous pressure, it results in venous hypertension, which increases the renal resistance and ultimately impairs the intrarenal blood flow. And we also know that there is very low oxygen tension in the outer medulla of the kidneys, which predisposes it to hypotension or hypoxia-induced injury. Now, this could be a basic or very simple explanation of why acute kidney injury happens in a setting of acute decompensated heart failure. So whenever there's an acute heart failure, we know there is going to be decreased cardiac output, which leads on to arterial underfilling, which leads to venous hypertension. It's not the primary fall in systolic blood pressure that worsens renal function. Why? Because whenever there is going to be increase in venous hypertension, the difference between the mean arterial pressure and the renal venous pressure falls, which leads to decreased renal perfusion pressure. So, but life is not so simple. If you have to put into nutshell all the types of cardiorenal syndrome into its pathophysiology into one slide, there is acute cardiac injury, be it acute or chronic heart failure. It leads on to hemodynamic changes in the form of decreased mean arterial pressure or increased central venous pressure, leading on to renal injury. On the other hand, you have a renal injury, which may lead to cardiac injury by means of either an anemia or a metabolic abnormalities, dyselectrolytemia or volume overload, etc. Now, also note there's a bidirectional involvement of humoral mediated injury, your renin-angiotensin RAS axis, your sympathetic nervous system activation, which can either originate in the cardiac system or in the renal system, having an impact on the other. You also have the systemic insult in the form of sepsis, diabetes, as I told initially, which is going to simultaneously affect heart and the kidneys. Now, how do you diagnose heart failure? You know, heart failure is going to be a complex mechanical neurohumoral syndrome, which leads on to stasis of blood in the periphery and pulmonary congestion. So the patient is going to present with effort intolerance and also edema. Now, mind you, these are not specific symptoms of heart failure, because patients with chronic kidney disease or an acute kidney injury also will present with these non-specific symptoms. So how do you establish the structural and functional derangement that are characteristic of CRS? We have the non-specific signs and symptoms, which can be backed up with biomarkers. You also have non-invasive imaging modalities coupled with invasive hemodynamic monitoring whenever necessary. And also finally, the adjuvant volume measurement techniques. Regarding the role of biomarkers, we have to agree that cardiology has actually made tremendous progress over the past decades. So in terms of biomarkers, they started with lactate dehydrogenase in 1960s and made their way up to troponin T and I, which has led to modifications in multiple therapies that they resort to, thereby bringing down the mortality to 50%. Whereas we nephrologists, on the other hand, still rely on serum creatinine for acute kidney injury. And most of our care is actually supportive. We've tried to fine tune all other drugs or the medications that the patient is going to be on, and still we meet up with high mortality rates in our patients. So there is still a need for early biomarkers of acute kidney injuries to facilitate better understanding, to provide early treatment and better outcomes in patients with AKI. So these are the list of biomarkers. So in the acute heart failure, you have the mid-range pro-atrial natriuretic peptide, you have the fatty acid binding protein. Along the chronic heart failure category, you have the FGF23, vitamin D, etc. Though we have an array of biomarkers on the kidney side, it is actually, we are still struggling with probably making cystatin C itself universally available. So whether we use these biomarkers in day-to-day practice from nephrology perspective is actually a question mark. But having said that, one thing that we always rely on or reiterate, keep emphasizing for every single patient that we see is performing an urine microscopy. Why? Because it is a readily available clinical biomarker, and it is going to help me in distinguishing whether the patient of interest is suffering from an intrinsic cause of AKI or the rise in serum creatinine is just because of a functional change. Also, with the help of cardiologists, we have the echocardiography, which will tell me the amount of congestion that the patient is suffering from in terms of central venous pressure, your systolic pulmonary artery pressure, or the pulmonary capillary wedge pressure, etc. There are a number of prediction parameters. For example, the decreasing left ventricular ejection fraction, along with few other parameters, which have shown to be independently associated with increased incidence of cardiorenal syndrome. Now, moving on to management, you have to understand the challenge here is going to be that each patient has his own unique medical history. His risk profile is going to be different from another patient, and also is going to suffer from multiple comorbidities. And also remember that most studies usually recruit patients who have got relatively preserved renal function, but that's not the case when we see in your intensive care setting. Yeah, so regarding the preventive approach, always try to see to that there are few risk factors that are addressed before you plunge on to treatment. So see to that the patient is not volume depleted. Remove other superimposed nephrotoxic drugs such as NSAIDs or aminoglycosides if they are prescribed for any other reason. Minimize the toxic exposure. For example, a patient who is going to be having acute coronary syndrome, you're planning for PCI, we are going to use contrast. But if you ask me whether the contrast is going to be a nephrotoxic, it is relatively nephrotoxic, but I'm not going to give you a red signal, because saving the patient is much more important than saving the kidneys, because I can always put the patient on dialysis. For that, the patient should be alive in the first instance. Also take care of, probably you can use antioxidant agents such as N-acetylcysteine whenever you're using a contrast. And so the treatment options, I'll be covering a little bit on each of these aspects: the diuretics, ultrafiltration, vasodilators, inotropic drugs, blockers of neurohumoral activation, and finally assist devices. Now, managing fluid retention and congestion is going to be the cornerstone of therapy, which is resorted to as high as 90% of patients. It does help in immediate relief of heart failure symptoms, but it does not have any long-term or short-term benefit in terms of mortality or rehospitalization. However, AHA has still endorsed diuretic use in heart failure patients with class 1 recommendation based on expert opinion alone. Now, this particular slide I want you to draw your attention to, because whenever a patient is going to have renal insufficiency, the more severe the renal insufficiency is, you may have to increase your dose of diuretic. There is no point giving a patient an IV Lasix of 20 mg or 40 mg and say that the fluid retention is not being taken care of. Now, that is because of a phenomenon called diuretic resistance. So what is diuretic resistance? It is the failure to decongest despite adequate and escalating dose of diuretics. This is because of insufficient delivery of the loop diuretic to the tubule, that is its site of action. This can be secondary to variable G absorption, more commonly attributed to gut edema. It could be secondary to hypoalbuminemia, decreased kidney perfusion, or reduced kidney function. And finally, this diuretic that is bound to albumin may have to compete with other substances such as urea or NSAIDs across the transport channels to take it to its place of action. And also there is heightened sodium avidity, by which I mean there is increased sodium reabsorption at the distal site, which drives diuretic resistance. So you may have to increase your dose of diuretic in treating such patients. Now, another question that we commonly encounter is whether to take these patients for ultrafiltration. So we have got a number of studies which include rapid CHF, unload, Caris HF, etc., which basically compares your ultrafiltration with diuretics. So though these studies have looked into this parameter, there's not been proven any, there is no any significant or superiority of ultrafiltration being established. Having said that, but if your drug therapy fails, you can resort to ultrafiltration as the last option. Now, role of RAS inhibition in CRS, it definitely brings about symptomatic improvement for heart failure, reduces hospitalization, and also enhances survival. A study which involves RAS inhibitor in CRS is SOLVIT study, which compared enalapril versus placebo. The main crux of the study is that across all levels of GFR decline, enalapril was associated with decreased risk of heart failure hospitalization, and also had at very increased level of GFR decline, it was still associated with higher mortality risk. So the important factor or the challenge in your case management will be, whenever you are starting a patient on a RAS inhibitor, you are going to anticipate a serum creatinine rise. Now, if it is less than 30%, especially in a patient who has got a heart failure with reduced ejection fraction, don't stop the drug unless the patient is going to have symptomatic hypotension. Whereas if the serum creatinine is going to increase by 30% or 50% or so, then either consider reducing the dose or temporarily withdraw the drug or stop the drug totally. So the point that I'm trying to make here is, whenever there's going to be a slight increase in serum creatinine, it is something what we call as permissive AKI, and don't stop the drug, all the more in a patient with reduced ejection fraction. The role of mineralocorticoid receptor antagonist, it's proven, it has a proven role in left ventricular remodeling. There have been multiple studies which has looked into spironolactone, eplerenone, and finally finrenone. The much hyped up study or much spoken study in the recent time is the fidelity analysis, which is actually a combination of Fidelio DKD and Figaro DKD. So it states that finrenone, which is a non-steroidal mineralocorticoid receptor antagonist, actually helps reducing the risk of cardiovascular and renal outcomes in compared to placebo in patients with type 2 diabetes and in all stages of kidney disease. So whom are you supposed to start on mineralocorticoid receptor antagonists? You have to choose your patient appropriately who has got a symptomatic heart failure but still preserved ejection fraction. With elevated brain natriuretic peptide levels, the eGFR should be more than 30 mils per minute, creatinine less than 2.5, potassium less than 5. Also note that you have to have a watchful eye. You have to closely monitor this patient's potassium and renal function while the patient is on MRA. The other drug in the armamentarium is going to be the ARNI, which is the combination of sacubitril and valsartan. So basically this drug almost and if congestion is also relieved. So
Ma'am, you're not audible. Subhashri ma'am.
Am I audible now?
கொஞ்சம் விட்டு விட்டு தான் மேம் வருது. It's not very audible.
So so is it fine? Are you able to hear me?
Now it's a little better, ma'am, but we are not able to see your slide. You can just summarize if you want also.
Yeah. So regarding certain across my trials, it's been Madam?
Hello, ma'am.
Yeah, is it audible now?
Yeah, now it's better.
Okay.
Okay,
So I'll
ma'am.
just finish off with the next 2-3 slides.
Yes, ma'am.
Is my slide at least visible now?
Yes, ma'am, it's visible. You can continue.
Great. So regarding sacubitril and valsartan, multiple studies have actually shown that this drug causes 30% lower risk of renal dysfunction compared to RAS inhibitor. Next on list is what you have, nesiritide. So nesiritide actually sorry for the technical glitch. Yeah, so nesiritide is basically causes vasodilatation at multiple levels. It's thought to increase natriuresis and improve GFR, but the results from SNHF trial has shown that it's not associated with either increase or decrease in rate of hospitalization due to heart failure or death. Now, inotropic therapy is used especially in type 1 CRS to improve cardiac output and reduce venous congestion. The conclusion of inotropic therapy is that it has a favorable acute hemodynamic effect, but not good long-term cardiovascular outcomes. A small word about low-dose dopamine, because it's something that we see on and off here and there. The proposed theory is that at low doses, dopamine will help promote renal vasodilatation, but meta-analysis have actually shown that low-dose dopamine increases urine output. There's no doubt about it on day one, but beyond that, there is no significant improvement in serum creatinine or output from day 2 and day 3. So the conclusion is available data does not give any favorable profile with terms to low-dose dopamine in treatment of acute heart failure. Now, there are a couple more drugs and inotropic agents, which I don't have any personal experience with, is levosimendan and omecamtiv. And finally, regarding cardiac resynchronization therapy, most CRT trials have not included CKD patients, but however, the post-hoc analysis of Miracle study have shown that it has shown improvements with NIHA classes 3 and 4 and ejection fraction across EGFR. The baseline EGFR category of this particular study was 30 to 60 mils. And no talk is complete without SGLT2 inhibitor in the current scenario. So there have been multiple studies that looked into role of SGLT2 inhibitors in the heart failure area and also renal outcomes. The take-home message from SGLT2 inhibitor is that it is associated with reduction risk of major cardiovascular events. It reduces the risk of heart failure, hospitalization, and also retards kidney disease progression. Finally, GLP-1 agonists, leader trial which use liraglutide and sustain 6 which use semaglutide showed that these two drugs help in decreasing the cardiovascular composite outcomes in terms of heart failure, myocardial infarction, etc. So keep in mind that management of CRS is not just about choosing what is the drug, also have a check on the other risk factors such as smoking, obesity, dyslipidemia. One thing that is probably overlooked or not looked at all is the calcium phosphorus abnormality. Keep in mind the genetic risk factors that may be playing a role in your patient who is not adequately responding to your treatment. So we are moving from one size fitting all to what is called precision or personalized medicine. To finally conclude, when you're treating a patient with CRS, there are 5 important questions that are supposed to answer. What is the fluid status? Is the blood pressure adequate enough to maintain renal perfusion? What is the cardiac output? What is the systemic vascular resistance of the patient? Or is there an intrinsic renal disease that is playing a part? So based on these 5 different questions, you're going to choose whether your patient needs your RAS inhibitors or you have to stop them. You need vasodilators or vasopressors, or should you just resort to diuretics or go on with ultrafiltration? So to conclude, cardiorenal syndrome is actually a very distinct entity from acute kidney injury, and it's not a very simple pre-renal component of AKI, which has to be looked into by means of physical examination, taking into a lot of parameters and under consideration, which will help in your management, thereby implicating the clinical outcome. So thank you for this wonderful opportunity, and I'm extremely sorry for the technical glitch in between.
Thank you, ma'am, for your excellent and highly informative talk. The topic is open for discussion. Doctors, you can unmute yourself and ask if you have any queries to ma'am, or you can drop your questions in the chat box. We can have it now or at the end also. Ma'am, you can stop sharing your screen also. As of now, in the chat box, we don't have much question, ma'am.
Sure. If anything pops up, I'll address there if that's fine with you.
Sure. Yes, ma'am. Yes, ma'am. Thank you so much, ma'am. If there are no more questions, we thank Subhashri ma'am for excellent presentation, and we shall move on to the next talk for today, which is about a challenging case of thrombocytopenia, which will be presented by our DNB postgraduate, Dr. Nikhil Govind, and will be discussed along with him by Dr. Manikandan sir, our consultant medical oncologist. Over to you, Dr. Nikhil.
Good evening, one and all. So we are directly going to the case. So the case is a 52-year-old female, a housewife, hailing from Thoothukudi, present with complaints of bleeding from tooth extraction site for past 1 week, and multiple reddish discolorations all over the body for last 1 week, and high-colored urine and blood in stools for last 4 days. Moving to the history of presenting complaints. So it was a 52-year-old female present with complaints of continuous oozing of blood from tooth extraction sites, which was done for dental caries 1 week back. After which she started noticing multiple reddish discolorations measuring more than 2 centimeters each, initially over the extremities, later extended to the trunk. History of passing high-colored urine and fresh blood in stool was present. There is no history of any swollen or tender joints. So moving to the past history, there is no similar episodes in the past. There was history of fever and body ache 3 weeks ago, for which she took the over-the-counter drugs. And there is history of intake of complementary native medicine for recurrent joint pains. There is no history of any diabetes, systemic hypertension, bronchial asthma, ischemic heart disease, valvular heart disease, cerebrovascular accidents, seizures in the past. There is no history of recent blood transfusions, or there is no history of any surgeries in the past. Personal history is not significant. Menstrual history also it's not significant. There is no history of any hematological malignancies or bleeding histories in the family. Patient was not on any antiplatelets or anticoagulants. So moving to the summary, it was a 52-year-old female present with mucocutaneous bleeds, bleeding from tooth extraction sites and multiple ecchymosis all over the body, with hematuria and hematochezia. There's history of fever and body ache 3 weeks back, and history of on and off intake of analgesics and native medicine for arthritis. And there is no previous episodes, and there is no relevant family history.
Dr. Nikhil, from history-wise, what are your possible conclusions from the history?
Sir, actually, from the history, we can see that the patient is having multiple superficial bleeding presentation like that. So it's actually means point out towards more favoring like a bleeding disorder rather than a clotting disorder. And from history, we are already asked in there is an history of any swollen tender joints like that. This mainly rules out the clotting disorders, coagulation disorders, since she doesn't have any deep bleeds. It is more superficial bleeds only. And on history, past history, there is no similar episodes in the past. That means particularly there is no childhood episodes of bleeding like that. There is it means like there is it is not a congenital disorder. It is a acquired one. And the patient is having a fever episodes last before 3 weeks. So it can be probably viral or a bacterial, which is led to the presentation, or patient is also having history of any intake of native medicines. It can be also a drug which may be cause this condition. And also we also ruled out any family history of any bleeding disorders also, and also the patient is not on any antiplatelets and anticoagulants. So from the history, we are coming to a conclusion like it is an acquired bleeding disorder, rather probably a bleeding disorder which can be more favoring a platelet or a vascular disorder like that, sir.
Okay, so which are the common drugs that can cause low blood counts or this bleeding manifestations?
Sir, mostly the majority of NSAIDs, then paracetamol, then anti-malarial drugs like quinine, like that. Then anti-seizure medications, carbamazepine, then then diuretics like furosemide. Then all majority of the all rheumatoid drugs, sir, gold, all things can cause, sir.
Okay, go ahead.
Okay, sir. So from at this point of time, the clinical diagnosis what we got is acquired bleeding disorder. Possibility, since there is a history of fever, is there 3 weeks ago. It can be a post-viral illness. It can be since patient was on native medicines, can be drug induced, or can be immune mediated. So moving to general examination, patient was conscious, oriented, and febrile. There is no icterus, no pallor, no cyanosis, no clubbing. There is no lymphadenopathy. There was oozing from the right lower third molar tooth extraction site, and multiple ecchymosis measuring 2 to 3 centimeters over the body. Few petechiae was there. Vitals pulse rate was 82 per minute, regular rhythm, normal volume, no special characters, and BP was 110/80 on the right upper limb. Temperature was normal. Respiratory was 14 per minute. Moving to the system examination, per abdomen there was no splenomegaly. There is no other masses palpable. CVS was not contributory. Respiratory system also normal. CNS was also patient was conscious and oriented, and fundus was also normal.
Okay, Dr. Nikhil, what is the uncommon in this presentation? Just go back one slide, go back 2 slides. Yeah, this slides. What is uncommon in this? You're expecting something, but that is not present here. Okay, if somebody is bleeding from multiple places, what is the thing that you expect here? Pallor.
Yeah,
Yes, no pallor.
Yes, sir.
So
No
has she
pallor,
received some
yeah.
transfusions before?
Yes, sir. No, sir. No transfusions was received, sir.
Okay.
Okay.
Okay, next slide. So assuming this patient has got a massive splenomegaly, what are your possible differentials?
Sir, possibility of if the patient is coming with any bleeding manifestations with the splenomegaly like that, first of all, foremost, we should rule out hepatic cirrhosis with portal hypertension, since it is a common thing, but it's female and it's not an alcoholic like that. So first and foremost, we should rule out that thing. After that, any leukemia, lymphomas like that, you should rule out, sir.
Okay, leukemias and lymphomas, very good. If the patient has got lymphadenopathy, what possible differentials would you think of?
Sir, first and foremost, sir, lymphoma only, sir. Then HIV is ruled out, sir. Any opportunity infections causing bleeding in immunocompromised patients, sir.
Okay, very good. So how do you like to proceed from now?
Sir, moving to the, sir, for the time being, the differential diagnosis what we got is mainly it can be immune or idiopathic, or it can be drug induced or infection induced. So moving to the investigations, total count was 7,900. DC differential count was 46.7, 45.2, and 8.1. Neutrophils, lymphocytes, and eosinophils respectively. SP was 12.3. Electrolytes were normal. ESR was 9 and 20. Platelets were 40,000. Uric creatinine was with a normal range only. Bleeding parameters was in normal range. And X-ray was normal. TFT was normal. Urine routine showed RBC, and motion occurred blood was positive, and random blood sugar was normal only. Then since the initial blood investigations were only platelet count was reduced, all of these lineages were within normal limits. For further step, we done a peripheral smear. We showed normocytic hemoglobin with severe thrombocytopenia. Then, in view of the history of fever, we had done a fever panel. We showed dengue IgG positive. reticulocyte count was 0.5 and serology was then just negative only. Coombs test was negative. RF factor was mild positive and other means vasculitis all profile was negative only. In order to rule out any iron deficiency or associated folic acid B2 deficiency, we have done all those tests which is normal only. Ultrasound was within normal limits. So since all these tests were we cannot find out a particular diagnosis, we move to bone marrow aspiration study, which showed a cellular marrow with normal erythropoiesis, reactive hyperplasia of myeloid series, and adequate megakaryocytes with reactive marrow, which is more or less normal. Okay.
So, Dr. Nikhil, when you're evaluating a patient with thrombocytopenia, what is the first thing that comes to your mind? Would you
Sir,
strike-
yeah, first and foremost, in patient with the thrombocytopenia, we should rule out any false positive. That is
So what is
pseudothrombocytopenia.
pseudothrombocytopenia?
Yeah, sir. Actually, means when you used to collect blood, when we mix with EDTA, there is high chance of clumping of platelets, which can produce a false negative, false positive of showing thrombocytopenia, sir. So you should rule out first that, then only you should do further investigation, sir.
Okay, so how do you diagnose pseudothrombocytopenia?
Sir, in peripheral smear, we can see the clumping of platelets, sir. Okay, sir.
So the machine count will be low, but when you
Yes,
count
sir.
manually, the platelets may be all right. And you can also use a different anticoagulant, sodium citrate,
Yes,
instead
sir.
of EDTA. So that will give you the exact platelet count. Okay, how do you like to proceed?
Sir, so far from the investigation we have done, we came to diagnosis like a prolonged thrombocytopenia, secondary to dengue fever, like that. So for the treatment given, patient was started on supportive treatment and routine blood products were given. And in spite of all the these measurements we have done, platelet count could not be improved. Hence, we started on steroids. We started on methylprednisolone 250 mg IV PD for 5 days, followed by Vislon 40 mg TDS for 5 days. After which patient started improving. So going to the course in the hospital, patient admitted with the mentioned complaints. Routine blood investigation showed platelet count below 50,000. Dengue IgG was positive. Patient started on blood products and other supportive measures. The patient platelet levels were not improving irrespective of the supports. On further evaluation, peripheral smear showed normocytic normochromic anemia with picture of severe thrombocytopenia. Coombs test ANA profile was negative. Iron profile with everything was normal range only. Ultrasound was not significant. Patient was improved symptomatically and got discharged at request. And after 1 week, she again readmitted with the same complaints. In view of the present thrombocytopenia, bone marrow aspiration was done, showed the reactive marrow, and patient was started on steroids on the 8th day of admission, following which platelet levels started to rise. On follow-up, after 1 week of discharge, patient platelet count increased above 1 lakh, sir. And we can see the increase in the platelet count as shown below in the table. And moving to the discussion. So whenever a patient comes with a isolated platelet count decrease, that is, first of all, as I told, we should rule out pseudothrombocytopenia. For that, we should do a peripheral smear for sure. So while when a patient comes with the platelet count less than usually 1 lakh, you should check all the lineages. If it is normal, you can go with the peripheral smear. And peripheral smear, if you are seeing any platelet clumping and all, you should rule out pseudothrombocytopenia. As I told, you should read out the blood in citrate and should check any which is a false positive or like that. And if you can see only there is a reduced platelet count, then you should consider drug-induced thrombocytopenia, infection-induced or idiopathic or congenital types. Okay. And if you see fragmented red cells, that is schistocytes. Okay. If you see like that, you should rule out MAHA, that is microangiopathy, hemolytic anemias, which is caused by DIC or thrombotic thrombocytopenia. You should rule out. So moving to the, as we already told, drugs causing isolated thrombocytopenia. These are the drugs which are causing this isolated thrombocytopenia. Paracetamol is common. We used to do. We used to give, and also NSAIDs I used to give regularly. So you should rule out all these drugs if the patient comes with isolated thrombocytopenia. Next, moving to the causes. The causes can be broadly classified into increased distribution or decreased production and increased sequestration and other conditions like congenital causes like that. So decreased production can be because of the congenital bone marrow failure or any acquired bone marrow failure. Increased distribution can be any immune mediated or any heparin-induced or thrombotic microangiopathy, dismantled DAC, and any other mechanical, particularly in patient with valve replacement, there is chance of breaking down of means platelets by the mechanical valve itself. Then increased sequestration, as I told, in cirrhosis, because of hypersplenism, there will be platelets will be low. Any other congenital conditions like name syndromes, you should also rule out. So this is a short means management profile of a ITP only that we usually used to see. In ITP, yeah, you should start with steroids, then only it will improve. You can start prednisone or dexamethasone. Add on like means IVIG or anti-D we can use, and platelet supportive management you can start. If it is not improving and persistent ITP, you should start immunomodulatory IVIG or a thrombopoietin receptor agonist like romiflostim, eltrombag or avatrombag. If it is not improving, as last step, splenectomy can be done, but it is not means very curative. And as an additional trial of events, we can add agents like a mycophenolate or chemotherapy or azathioprine like that, sir. Over to you, sir.
Yeah, good evening. So I'm thankful to Professor Arulrhaj sir and Aarti ma'am for the kind invitation. So Dr. Nikhil has presented very well about this thrombocytopenia. I'm here to just add few more points. So from the history, one thing we should do is always try to get the patient's record to see whether any prior blood counts they have. So from in that sense, we'll come to know whether it is an acute low count or it has been a chronic event. And the second important point is history of native medicines. Many of these native, especially herbal medications, which our patients take on a long duration, could cause pancytopenia or thrombocytopenia. And very importantly, before you order a series of battery of investigations, we have to rule out pseudothrombocytopenia, which is very common with when EDTA is used as an anticoagulant. So due to platelet clumping, the automated cell counter will show a low platelet count. A simple peripheral smear or a manual platelet count could actually identify this pseudothrombocytopenia. And we should also never forget the commonly used drugs that can cause thrombocytopenia, like the Bactrim DS, cotrimoxazole, and also especially in patients in the ICU where heparin, especially heparin-induced thrombocytopenia is an entity per se. After 4 or 5 days of heparin infusions, these patients can have low platelet counts. And also not to forget, some of our, we have experienced a scenario wherein a hematologist was evaluating a patient with low platelet, and actually the patient had denied or concealed the history of having a cancer for which the patient has received chemotherapy. So we have to bear in mind that chemotherapy and also radiation could cause pancytopenia or thrombocytopenia. And always before you order a series of tests, the first testing should be a simple peripheral smear. So this peripheral smear will give us a lot of clues. So if it is an acute leukemia, you will see the blasts. And if there are a lot of broken RBCs, then your diagnosis is like DIC or TTP or HUS. And it could show a malarial parasite where the diagnosis clinched as a malaria. And you could also see the other cell lines, whether it is only a drop in the platelet count or a drop in the white cell and the RBC. And also not to forget the very common nutritional deficiencies that is common in our patients, like iron deficiency anemia, folic acid deficiency, and B12 deficiency. Iron deficiency commonly presents as thrombocytosis, but also it can present as thrombocytopenia. And in general, once we kind of do a good history and examination and the brief test, still if the diagnosis is uncertain, then we order a bone marrow examination. And it is very important to know that bone marrow is a very painful procedure, and it should be done as one shot, and all investigation should be collected, because sometimes we do a bone marrow aspiration and then we find a diagnosis, and then we need a flow cytometry or biopsy, and definitely the patient will not be willing for a second bone marrow examination. So the bone marrow, we should do a bone marrow aspiration. From the sternum, it is only the aspiration we could do. From the iliac crest, we could do, in addition to the aspiration, a bone marrow biopsy also. And it is also preferable to take an additional sample, wherein for sometimes like acute leukemia, wherein you need a flow cytometry, if we take an additional bone marrow sample, it would be good for us in case if it is an acute leukemia, then a flow cytometry or a molecular or cytogenetic panel could be ordered. And regarding platelet transfusion, generally patients do not bleed spontaneously until the platelet is less than 20,000. So prophylactic transfusion is only for very sick patients of platelet less than 50,000 or asymptomatic well patients with platelet less than 20,000. So there are two modes of transfusion. One is a single donor platelet. Currently, that is not available in Thoothukudi. We have random donor platelet that is available in various blood banks. So each RDP will increase the platelets by around 5,000. Generally, somebody with bleeding, either bleeding with low platelets or somebody with a platelet of less than 20,000, we transfuse 4 RDPs. So that will effectively increase the platelet counts by around 20,000. And also, it is very important to note that these platelets should not be stored in the refrigerator. It should be always at the room temperature. If it is kept in the refrigerator, then there may not be adequate platelet increase. And also, it is very important to know that once you receive the platelets from the blood bank, immediately you have to transfuse it as rapidly as possible. Because if the platelet is kept in the ward, immediately it will lead to platelet clumping. And if a patient is, say, having fever, or if the patient is currently unfit for the platelet transfusion, probably we have to keep it in the platelet agitator to prevent this transfusion. So the platelet transfusion is an immediate way for somebody with low platelet. And the diagnosis of ITP is actually a diagnosis of exclusion once you exclude all the possible causes. And the treatment per se, currently we have two, if the acute ITP, the treatment is either steroid or intravenous immunoglobulins. And we also have other drugs currently available. That is, one is romiplastim, that is a subcutaneous given drug. And also there is an oral drug called Thrombopac. So, so in general, overall, the management of low platelets, one is a very good detailed history, and then immediately quick minimal investigations like a peripheral smear, and bone marrow is done once we have not found suitable diagnosis. A bone marrow is done. Thank you very much for the opportunity.
That was a very interesting case discussion we had today. Manikandan sir, we have 2 questions for you in the chat box. You can just take it up and finish it quickly, sir. Hello. So I don't think sir is there. Manikandan sir?
Yes, ma'am. Yes, ma'am.
I have
Regarding
two
CLD with diabetes, whether the bad impact of permissible thrombocytopenia, any comments, sir?
It's from Dr. Kannan Natarajan, I think, to you, sir. Can you just give a few short comment on that?
I'm sorry, actually, I don't know the answer for this question. If there is somebody else who can answer this question.
Yeah, we'll ask our chairman, sir. When he gives the comments, we'll finish it. We have one more question, sir. Comparison between dental extraction and ill-fitting dentures regarding prognosis in ITP, sir, from Dr. Sanjay Srivastava, sir.
I think there is no prognostic impact, but definitely if somebody has got low platelets, a dental extraction could be a very serious problem. So the minimal procedures like scaling or filling wouldn't be a problem, but definitely extraction, root canal, or an implant, definitely before sorting out the issue should not be undergone.
Okay. Thank you, sir. We thank both Nikhil and Dr. Manikandan, sir, for their excellent case discussion. Now we shall move on to the last agenda of today, for which we request our chairman, sir, to give his concluding remarks about the 2 cases and also discuss the answers for the clinical album. Over to you, sir.
What was the question that was put forth to Manikandan? First question.
So, first question was a patient with chronic liver disease with diabetes. Whether will he have the pathological impact of permissible thrombocytopenia?
Definitely.
Yeah.
Definitely, a patient with liver disease will have more impact of the thrombocytopenia, because he has already a bleeding tendency, and his thrombocytes will be low. Therefore, he will suffer more. No doubt about it. We will have to be very careful. That is why we give fresh blood transfusion or FFP for patients with liver problems. Now, before going to the answers for the clinical album, first of all, I would like to congratulate Dr. Subhashri a very young nephrologist of our city, for an excellent discussion on the cardiorenal syndrome, because it is a common issue that we on the, critical care side, every day in and out meet, and physicians, cardiologists, nephrologists. She has very nicely classified and the pathogenesis and management. I'm sure based on her, clinical approach, we'll be able to early recognize and prevent the occurrence. See, more than the treatment, prevention of the occurrence of renal, failure in case of cardiac failure is important, though it may be little beyond our level. An adequate fluid level will definitely, prevent a renal failure. That is my concept on that, which all the clinicians accept. Secondly, regarding the thrombocytopenia, Nikhil, presented very well. Very excellently well. And there was an exhaustive discussion on thrombocytopenia by our medical oncologist, Dr. Manikanda. The key here is there is a thrombocytopenia and there is no splenomegaly. An earlier patient was all right, and all complications of bleeding are due to thrombocytopenia. What is the cause for it? Whether it is a benign ITP or a prolonged thrombocytopenia due to a dengue, or whether it is a part of pancytopenia. That is our issue. And the key is our bone marrow, which rules out a pancytopenia, which is a priority or part of aplasia. Aplastic anemia of the bone marrow, it is not there. Dengue, possible. And an ITP without a splenomegaly, I never make a diagnosis. We always call it as a very soft, tender spleen. You will have to put the patient on the right lateral position and put in your hand into the right costophrenic margin, ask you to take a deep breath, you will hold it, because the painful spleen is touching that. Without that, it is difficult. And the treatment for ITP is only steroids. We may temporarily overcome that by platelets or FFB or fresh blood, but steroids. But here in this lady, the count was very low. That is why a lot of bleeding throughout. Bleeding, skin cutaneous bleeding was there, mucosal bleeding was there, GI bleeding was there, urinary tract bleeding was also there because of the very low, platelets, which did not go up substantially with our, transfusions. Beyond 43 or 44, it did not go. That is why we started on steroids. It immediately shot up to 1.2, 2 lakhs, and then we have started reducing it. Still, we are, stuck between the two, either an ITP or this. But since bone marrow is normal, spleen is not there, we always vote for a prolonged thrombocytopenia secondary to, our dengue. The final answer will come when you stop the steroids, when the platelets are maintaining at that level, we will be definitely able to conclude that. Now coming to the, today we have an excellent collections. My appreciation to our postgraduates, they have made excellent collections. There is a good star, clinical picture here, spotter. You will immediately say it is not a Bell's palsy, lower motor neuron paralysis of the left seventh nerve. That is the diagnosis. The eyebrow, is not raised, eye is not closed, nasolabial fold is gone, and there is a deviation to the opposite side of the angle of the mouth. This is not moving down, and the neck muscles are also weak. That shows it is a lower motor neuron palsy of the left seventh nerve. Commonly, we call it as a Bell's palsy when there is a lesion at the stylomastid foramen. But here the issue is the cause is different. Here the cause is a trauma. There is a fracture here in the mastoid bone and the temporal bone. There is a, deficiency here, and that has compressed on the nerve, and that is why this. Commonly, we use some steroids or anti-inflammatory drugs or stimulations. Same thing we will use here also, but the outcome may not be to your expectations. In seventh nerve palsy, Bell's palsy, due to an edema, it will definitely recover. Whereas here it will take a lot of time to recover. Sometimes you may need a plastic surgery for the face. That is a thing we should know. Upper motor, lower motor, cause of it, outcome of it. You should tell to the patient. It will take long time. Sometimes may need surgical therapy. It's a very interesting, ECG and X-ray. X-ray, you will immediately make a diagnosis that the heart apex is on the right side and the gastric bubble is also there. On the right side, there a cardiac shift and a entire intestinal shift. There is a situs inversus totalis, not a dextrocardia alone. Come to the ECG, you will be able to, this is the, ECG, all components, all waves in the lead 1 are inverted, all waves in the lead 3 are upright. That makes you to think that it is a case of, dextrocardia. And in dextrocardia, there are, and the chest leads also should be, low complexes. You have a dextrocardia situs inversus classical, and you have a isolated dextrocardia. Only heart is on this right side, and the entire stomach and liver are on in their place. That is a dangerous condition. You will always have a lot of, complication, AV abnormality or a stenosis, AV canal problems can be there. Sometimes there can be a dextroversion, slight rotation of the heart. There also heart is normal. There can be a full, if there is a fibrosis on this side, it can be full, and that is a pseudo dextrocardia. There is a technical dextrocardia, which the technical person can place the, leads, abnormally the right side and left, you will have all here inverted, but chest leads will be normal. Thereby, we will be able to make a diagnosis. Always dextrocardia, situs inversus benign. I have made this diagnosis on many ministers of our Tamil Nadu. Don't worry about it. Here is a problem. A 65-year-old man, he has come for a different complaint. He has come for a chest problem, which is diagnosed with coronary heart disease, under treatment. On seeing him, I found a lot of interesting things. You see here, lot of folds and bubbles coming up. These are all due to lipomatosis, due to multiple lipomatosis. That was interesting, though it can be benign. And you will have to make a diagnosis of, by doing the slip test. And there can be a Gordon syndrome, Dercom syndrome, all those things can be there. Usually it is benign. But when there are internal lipomatosis, you can have a neurologically lesions, neuropathies, or intestinal obstructions. Sometimes it may go to sarcoma, especially retroperitoneum. Therefore, when you see multiple lipomas, you will have to do an evaluation to see that there are complications. This man was free of all these complications. It's an interesting thing that I wanted to show how a PET CT will look like. We have seen a single slide, 4 slides, multiple slides, 64 slides CT. We have seen MRI at various strengths. This is another one. It's a PET CT, which is a total body, imaging based on the metabolic activity of the lesion. This is a very interesting case. A lady had a thyroidectomy, had multiple lesions in the neck. We did a biopsy, and finally we suspected that there can be additional malignancy. Therefore, we did a PET CT, and it showed another primary. There is the primary in the thyroid operated, another primary here in the breast leads on to lot of nodes, including mediastinal nodes, and the thyroid also. The value of PET CT is for localizing the lesions and trying to find out the systemic spread of a malignancy. It's a very young, old lady. You are able to see multiple bullous, something like bubble lesions. You will have to see. You can see that on the leg or on the face. Usually, you just see that it is a bullous phebicus vulgaris. That is the commonest lesion, which may need steroids. You should know that. Otherwise, it can go systemically and cause a lot of vascular complications. And this is a person, about 60-year-old man with a chronic liver disease. He was brought with hepatic encephalopathy. Clinically, his ventral obtundation is there. You find a liver flap, and you can have some tremors and sometimes some breathing abnormalities. Of course, the liver parameters are abnormal, ammonia is raised. But but sometimes when the patient comes to you fresh, you may be, you may be troubled to say whether it is a liver hepatocoma or not. EEG will come to your help. When there is a triphasic slow wave, this is classical for a hepatic. It is called as a triphasic wave or a delta wave. Always things, hepatic coma. It can also be a forerunner. In a liver disease, if you make do a EEG and see the triphasic wave, delta wave, you can predict this person is entering into hepatic coma. You can take the necessary steps. It's a very, interesting lung problem. You find a very beautiful cavity in the right upper lobe in the posterior segment. And this is very classical. When there is a lesion, upper lobe, posterior segment, cavity, it is tuberculosis unless proved otherwise. And the cavity has got multiple problems. Cavity is always has an open tuberculosis. It can spread. And sometimes a blood vessel can run through this. And sometimes a vigorous cough can cause hemoptysis. What we call it as an Anthony Muthu syndrome. Can have a fungal ball. Lot of things can have a pneumothorax. Lot of things can be there. There are any number of causes for, cavities like cysts in the lung. But upper lobe cavity, posterior segment, it is tuberculosis unless proved otherwise. And here there is a patient who is immunocompromised, young chap who is immunocompromised. His HIV is positive, CD4 count is very low, only 120. And he has come with a cough and breathlessness and weight loss, sees X-ray, something like a miliary lesion. We made a clinical diagnosis of miliary tuberculosis. But when we did all this other investigations, TB was positive, no doubt. The HIV was also positive. CT showed not multiple nodular lesions as with tuberculous lesion. Small. Cysts are also seen here. Here. It is typical of pneumocystitis carinii. We will have to be very, very careful. Immunocompromised chap has got HIV. Has got a tuberculosis, pneumocystitis carinii, a double dose of a 4-tremoxazole with a good nutrition always improves them. Patient is on treatment, but still there is a very high risk for life as well as pneumothorax. Here there is a 58-year-old male came with he is a chronic alcoholic, now and then got treated. But this time when he came, he had an distended abdomen. When we palpated the abdomen, the liver was enlarged, but it was hard and nodular. We put the stethoscope, looked for a systolic murmur, but it was not there, but a hard mass, irregular mass. And immediately we made a clinical diagnosis of, hepatoma of the liver, chronic liver disease going in. Alpha-fetoprotein was positive. An MRI showed multiple lesions. We did a biopsy, came out as hepatocellular carcinoma. He is on immunomodulator, sorafenib, and he is pulling on. Here is a case of an acute, there are today now, alcoholism has become an order of the day. Therefore, diseases related to alcohol are also very common. You see here, multiple cases are only alcoholics. Here is a young alcoholic who enjoyed life. By drinking alcohol, came to the hospital in the morning with epigastric pain. You see that radiating to the back. An epigastric pain pulling. I used to say pushing to the back, punching to the back. Always think it is, pancreatitis unless proved otherwise. You can see the serum amylase, lipase levels, and ultrasound can show you, enlarged, pancreas. But the gold standard is always, CT scan. And here you see the ducts are dilated, any mass lesions, any collections, abscess, cyst, everything you'll be able to see. And usually they do well with the conservative treatment. When complications are there, surgery has to be done. Very interesting case of again an alcoholic and smoker, and had acute chest pain, diagnosed as an inferior valve myocardial infarction, and he was thrombolized. As he was thrombolized, he was settling. He started having a tachyarrhythmia, classical ventricular tachyarrhythmia. See, during thrombolysis, short runs of VT are very common. Needs only observation, does not need treatment. But when it is continuously coming up, you will have to treat a synchronous, a DC shock or a cardron, infusion or a beta blocker helps it. But this patient was given cardiogenic shock and he improved it. and recovered. This is a inferior enforcement settling. The lesson here is a VT which is not in, in runs, continuous VT, don't wait. Immediately you do a, shocking and see that the patient is recovering. We should know, I think this is the last one. We should thank all the, presenters and participants for the excellent digital, CME to upscale our clinical knowledge. Sure, we'll do more in the years to come. Thank you all very much. Good night.
Thank you, sir, for your valuable clinical discussion. We thank all our colleagues once again, and let us all meet again next month with another few more interesting clinical discussions. Till then, stay safe and healthy. Good night to one and all.
Thank you, madam.
Thank you, Hari sir. Thank you so much. உங்கள இருந்து நிறைய பேர் ஜாயின் பண்ணிருக்காங்கன்னு நினைக்கிறேன் இந்த வாட்டி.
Thank you.
Thank you so much, sir. Good night, sir.